Hello everyone. Today we're going to start with dermatology. Coming to dermatology, the first one will be epidermis. Epidermis has many layers, starting with stratum basale, then stratum spinosum, granulosum, lucidum, and corneum. Stratum basale is a single layer which will be composed of all mitotic cells. All the division will start here, then it will progress upwards. And coming to spinosum, this contains of all the keratinocytes and Langerhans cells. So this is the most thickest layer. As you can see from here to here, it will be full of spinosum. And spinosum plus basal together it is called as stratum malpighi. And granulosum. Granulosum contains, as the name says, contains granules. It has two granules, keratohyalin granules and woodland bodies. Woodland bodies contain lipid which makes the skin water impermeable. And coming to lucidum, lucidum is present only in palms and soles, which makes palms and soles skin thicker. And stratum corneum, this is the last layer to be formed. So this contains of dead keratinocytes, and this layer will be typically absent in preterm babies, as only after maturity this corneum will be formed. And stratum corneum is also called as horny cell layer. This lucidum is also called as clear cell layer. Then spinosum is also called prickle cell layer. So these are the layers of epidermis. Then, as already said, this basal, this is the first layer, will be called the base layer. The cells after proliferation move upwards. The entire time from basal till corneum till shedding off, it is called as ETT, epidermal turnover time. This is typically around 56 to 72 days. So if the ETT is reduced, then it will cause psoriasis. In psoriasis, the turnover will be very high. So that's why scaling forms. So the skin cells will shed faster, will appear as white scales. Then now coming to the color of the skin. So the stratum basal layer can also contain melanosomes. So for example, if this is a melanosome, it will contain projections to spread the melanin pigments. So based on the size of vesicle and the melanin pigment present, they will be divided into 6 types. So type 1, 2, then this is 3, then 4, 5, 6. So starting from the white to black. So this type 1 will be like completely white in color. So we have two pigments in melanin. It's called as eumelanin and pheomelanin. Eumelanin is black. Pheomelanin is actually lighter shade of orange or something like that. So when pheomelanin is high and eumelanin is low, type 1 will be formed. When eumelanin is high and then pheomelanin is low, it will be type 6. So based on this, we are grading it. It's called as Fitzpatrick scale. So most of the Indians come under type 5, then type 4, and less likely type 3. These three types are mostly found in India. Then coming to type 1, in type 1, if they are exposed to sun, they will experience burns, but they will never tan. On the other hand, if type 6, they will never experience burn, but they will tan. So the malignancy potential is more for type 1. Then it will drop down. It will be very less for type 6. So how does the person get even color? So if you see, every person has a even skin tone over their body. So that's because of this thing called as melanocyte unit. So epidermal melanocyte unit. So this thing, for example, this is one melanocyte. It will supply to 36 keratinocyte. This is constant in every person. So this thing will confirm that the skin tone remains even throughout the skin. So now after completing epidermis, we'll come to dermis. So this layer is the dermis. This will be subcutaneous layer, and this one will be epidermis. So in dermis we have two types, two divisions: papillary dermis, reticular dermis. So the upper 10%. So if this is the dermis, now upper 10% is called as papillary dermis. And the lower 90% is called as reticular dermis. So the papillary dermis and reticular dermis is divided. Then the dermis contains cells called as fibroblasts most commonly. Fibroblast, other than that, it can also contain mast cells and macrophages. And these fibers will be made of collagen. So collagen, then second most common will be elastin. These fibers are present will preserve the elasticity of the skin, and the blood supply will be till dermis. So dermis will get blood supply, but the epidermis won't get blood supply. So epidermis is avascular. Then coming to subcutaneous layer. So after epidermis, dermis, then subcutaneous layer, they will divide into many lobules. So we can see this is a lobule. Everything this one part is a lobule. This will be separated by a septa, fibrous septa. So subcutaneous is also called as panniculus. If inflammation of subcutaneous occurs, then it's called as panniculitis. Then inflammation occurs only in septa, it's called as erythema nodosum. If it occurs in lobules, then it's called as erythema induratum. So after completing the layers of skin, we'll come to lesions present in skin. So coming to the most common lesions, so this one is called as macule. So macule, it means that if the diameter of the lesion is less than 1 centimeter and there is no elevated or depressed thing, so that's the color change which has a diameter of less than 1 centimeter. The same color change which has diameter of more than 1 centimeter is called as patch. Then if there is elevation present over the lesion, it is called as papule. And here the diameter is less than 1 centimeter. Again, if the papule, if it is contain a pus, so you can see here that this papule contains pus inside. So it's called as pustule. So even here the diameter is less than 1 centimeter. The same papule, if it contains fluid, clear fluid, and this is called as vesicle. If the diameter is less than 1 centimeter, the same vesicle has become diameter more than 1 centimeter, it is called as bulla. So in this one, if the papule is bigger, so the papule with diameter more than 1 centimeter and also it contains deeper structures called as nodule. Then if the nodule itself, it contains a cavity and there is something filling it now, it will be called as cyst. So difference between nodule and cyst, it can't be made out using plain eye. There should be investigation. For example, some ultrasound, we can detect the fluid inside the cyst, so that it will become a cyst. Otherwise, if it is solid lesion, it will be called nodule. So then coming to plaque. So if many papules are small, light raised lesions. So if many papules join together, it will form a plaque. This is characteristic seen in psoriasis. So then coming to special lesions. So these are special lesions. This is called as comedone. So these are popularly called as whiteheads and blackheads. These will be most commonly seen in acne. So these are open heads, open comedones, which are also popularly called as blackheads. So these are all the white thing is called as closed comedone, which is popularly called as whiteheads. We'll discuss about acne later. So this one is called as target lesions. So characteristically seen in HSV. So there will be a centrally placed macule or papule, then surrounding erythema will be present. This is also associated with some drug induced, some fixed drug induced lesions. Then this is also a special lesion called as burrow. This is characteristically seen in scabies. So after lesions, we will come to instruments are used to detect these different types of diagnosis. So this is called as Wood's lamp. So this will have a fluorescent blue color light which has a wavelength of 365 nanometer. And this filter is called as barium silicate nickel oxide filter, which will uh, characteristically shade the different diseases color into different thing. We will see each disease which shows which color. Then coming to diascopy. So diascopy means using glass light to put pressure over the area. So if it blanches now, it will be mostly erythema. If it doesn't blanch on pressure now, it will be mostly purpura or pedicle spots. So this one is called as Zang smear. So the procedure is simple. Just if we'll take a blister or a bulla, then de-roof the thing, then take the fluid and put it on a glass slide. After glass putting on the fluid and glass slide, we'll apply Gamesa stain. Then observe this thing under microscope. So we can have findings like this. Under microscope, if the cells appear like this, large cells with large nucleus, it is called as acantholytic cells. This characteristic is seen in pemphigus. Then if the cell appears like this, a single cell with multiple nucleus, this is called as MNGs, multinucleated giant cells, which are seen in herpes. Then this is also pemphigus. Then this one is leishmaniasis. So Donovan bodies. So this cell is called as acantholytic cell is called as Zang cells. And coming to patch test, this is done to identify which is the allergen which is causing the allergic dermatitis. So this one will be mostly stuck into upper back and left out for 48 hours. It should be read after 48 hours. The most ideal time is after 96 hours. Then this will show whether the person has type 4 hypersensitivity reaction. Then these are called as Blaschko lines. This might look like a Langer's line, which is used in surgery to make the surgical incision very smaller. But this is called as Blaschko lines. This will show the migration of cells. So primitively from embryology, the cell development lines from here it will move away. So the keratinocyte movement will be shown by these Blaschko lines. So after skin will come to hair. So this is the hair cycle. So first starting from anagen phase, is called the active phase. It will occur for 3 years. Almost 85% of all the hair which we currently have will be in anagen phase. That is the growth phase. Then catagen phase called as transition phase. It will be there for 3 weeks. And approximately only 1% of the hair will be in catagen phase. And teogen phase is called as resting phase. This will be for 3 months. So almost 15% of all our hair will be in resting phase, 15%. Then these will fall off, and again the another phase, the growing phase will start. Again a new follicle will start growing, and again the cycle will continue. This is called as hair cycle. So now coming to androgenetic alopecia. Androgenetic alopecia typically occurs in male, but it is also possible in females. So if it occurs in male, it will usually of this pattern called as Hamilton pattern. So I'll start here. So this will be a bald spot. Then the forehead will be receding from the temples, and it is called as Hamilton pattern. If it is diffuse, if it starts like entirely diffuse, mostly seen in females, it will be called as Ludwig pattern, and there will be, for example, frontal accentuation is called as Olsen pattern. This is also commonly seen in female type of baldness. So firstly, it will be from the center. There will be thinning of hair follicles. Then it will generally become diffuse. Then the entire hair will fall off. So this is genetic and is called as non-scarring alopecia. So why? Because non-scarring means there won't be any scar formed. So this one is called as alopecia areata. Okay, so treatment for this one will be minoxidil and finasteride. So which are anti-androgens which will prevent the actions of DST. So DST causes hair loss. So this finasteride will prevent the formation of DST. So coming to alopecia areata, this is due to autoimmune condition. So autoimmune cells will affect the hair root and make a patchy hair loss present here. So this is called alopecia areata. In alopecia areata, there are many types. Like this is a classical type. In classical type, there will be patches of hair loss. There are something called as totalis, where the entire scalp hair will fall. There's something called as universalis, where even the eyebrows, even the mustache, everything will be fall. That's called as universalis. So for treatment for this will be, first you'll see the findings. So for example, if this is the patch, on the boundary of the patch we'll see something like this. So this is called as exclamatory mark sign. The hair will be thin on the start and it will be thicker. So we'll call it exclamatory mark. So this is a characteristic finding of alopecia areata. Then if we take the hair follicle and we examine under microscope, we can see that there will be lymphocyte aggregation surrounding the hair follicles. That's because of autoimmunity. This is called as swarm of bee appearance. This is seen in alopecia areata. Then apart from this, there will be nail pitting also seen. So there will be nail pitting, which will be regular and shallow. Regular and shallow nail pitting. Is seen in alopecia areata. So coming to the treatment, if it is a classical short small patches, then we can apply topical steroids or intralesional steroids. There will be steroids will be applied intralesionally. So it will be intralesional steroids. So it is totalis, na? Like it is a bigger lesion, then we will go for topical steroids plus oral steroids for both things. This will allow the hair to grow again in that place. Then now coming to nail changes. So firstly, if pitting, if it is regular and shallow, it is due to alopecia areata. If this is irregular and deep, it is seen in psoriasis. So this one is called as spoon-shaped nail, also called as koilonychia. Typically seen in iron deficiency anemia. Then this one is called as leukonychia. It is a typical white line present on the nail, which is called as Mies lines. It is seen in thallium poisoning or arsenic poisoning. So these Mies lines, if we try to press it now, the white line doesn't fade away. This is called as true leukonychia. This is true leukonychia. There is something called as apparent leukonychia. So in this thing, if you try to blanch the nail surface, then the white lines will disappear. So that's called as apparent leukonychia, and this one parallel lines are called as Muir-Case lines. So this is seen in hypoalbuminemia. So you can see in patients with DCLT in your wards, so they'll have these type of lines which due to hypoalbuminemia, or patients in chemotherapy also might have these lines. Then this is called as Lindsay's lines. Lindsay's nails. In this thing, the proximal half, so this proximal half will be white in color. So this is called maybe due to chronic renal failure. So this is called as cherry snails. This in this the entire nail will be white in color, leukonychia. So this is probably due to hepatic failure, liver failure. So chronic renal failure will be 50% called Lindsay snails and Terry snails due to hepatic failure. So coming to paronychia. So paronychia is an infection of lateral nail folds. It could be due to bacteria, which will be acute, or it could be mixed due to fungal, which will be chronic in nature. The treatment will be IND. So incision drainage along with oral antibiotics will treat it. Then coming to Bewes lines. You can see this forms like a ridge over the nails. So this is due to arrest in the nail growth during the infection. If there is a infection during the growth, there will be abuse lines. And this is called as nail fracture, also called as onychomatosis. In that there will be fracture of nails. Then coming to onychocryptosis. This is toe ingrown nail. That's called as onychocryptosis. Okay, then after nails we'll come to disease of sweat glands. So first we'll be seeing about eccrine sweat glands. In eccrine sweat glands, the most common seen is prickly heat. So it's also called as miliary. So due to blockage of the eccrine sweat glands. So next we'll come to apocrine sweat glands. So apocrine sweat glands present in axillary region. If there is follicular occlusion, it will cause adenitis. It is called as hidradenitis suppurativa. So there will be nodular lesions present, and there will be interconnecting bridges present between the lesions. And the treatment is with doxycycline or isoretinoin. Then now coming to sebaceous glands. So sebaceous glands, if it is present in abnormal areas like over the lips, usually sebaceous glands are not present over the lips. So if it is present, it's called as Fordyce spots. So these actually doesn't require any treatment. If it is cosmetically affecting, then we can go for laser excision or something like that. And this is called as rhinopyma. This is also due to sebaceous gland. It's also called as potato tumor. So it appears like a potato over the nose. So even this thing can be attributed to sebaceous glands. So sebaceous gland, if it undergoes any hypertrophy, sebaceous hypertrophy, then it will appear as potato tumor. So treatment is with CO2 laser excision. Then now coming to acne. So acne is a very common skin condition which affects mostly puberty people. So the most characteristic lesion will be this comedone. You already seen whiteheads and blackheads. Blackheads are closed. Then this whiteheads are closed and blackheads are open comedones. Then there will be also presence of any papules, pustules, and nodulocystic acne also. This nodulocystic is the most dangerous form. It's a bit difficult to treat and it can cause immense pain. It's the most severe would be the most accurate word. Most severe, and it's also called as acne conglobata. Then for treatment of acne, treatment will be usually of topical retinoids. So if it is in the severe form like nodulocystic, na, we will go for oral retinoids. Oral retinoids have many contraindications, so that should be seen before giving it. So, including it will have teratogenicity. So, for pregnant females, we can't give oral retinoids, and it may cause depression. So, we can't give for psychiatry patients. It may cause dyslipidemia. It may cause night blindness. So, oral retinoids are mostly given only after proper screening. Then coming to rosacea. So rosacea, this one looks somewhat similar to SLE. So this appears like a malar rash. So this will be confused with SLE, but there are many types of rosacea. Like the most common being erythematotelangiectatic rosacea, in which there will be red face. So typically வந்து ஒரு middle aged patient வித் இந்த மாதிரி ரெட் கலர் ஸ்பாட்ஸ் ஓவர் த ஃபேஸ் இருக்கும். ஸோ அது வந்து ஆல்கஹால் ஆர் ஸ்பைசி ஃபுட் சாப்பிட்டாங்கன்னா இன்க்ரீஸ் ஆகும். ஸோ தட்ஸ் கால்ட் அஸ் ரோசேசியா. தென் ஈவன் ஆன் டேக்கிங் ஹாட் பெவரேஜஸ் லைக் காஃபி, டீ, this redness will increase. So this is called as rosacea. So treatment of rosacea will involve first you have to do a KOH mount and find Demodex mites. If it is present, now we will give metronidazole gel. Gel plus isotretinoin. So this is a treatment for rosacea. Rosacea can be associated with rhinopyma, potato tumor also. So now coming to eczema and dermatitis. So eczema. So eczema or dermatitis can be due to irritant or allergic. So first this is called as ICD, irritant contact dermatitis. When there is a contact between irritant particles like detergent or any dishwashing fluids or any sanitizers. So due to detergent it can cause ICD, which is commonly called as housewife eczema. So usually the person who washes the utensils will be contacting their hand with detergents. So it may cause a dermatitis like this. It's called as ICD. It's most commonly due to detergent. Then if it is due to allergic causes like ACD, allergic contact dermatitis, it will be due to this plant is called as Parthenium hysterophorus. It is also called as Congress sweet. So this thing, it is not a native plant to India. Actually, when India was back in the day, when it was almost in a famine, they imported wheat from America. So during the period of Congress, they imported wheat from America to India. So in that wheat thing, there was a weed. This the spores of Parthenium hysterophorus. This thing was also present along with the wheat. When that came into India, it got planted into the soil and it causes this wheat to grow. So this Parthenium will release pollen. This pollen will cause allergy. So this Parthenium hysterophorus, you can find this plants on the roadside, which is the most common cause of phytodermatitis. So plants causing dermatitis, this one is the most common cause, and it is also called as ABCD. So because airborne contact dermatitis, so airborne, the pollens will come through air and cause allergy. So an allergy can be caused due to various other causes like rubber slippers or bindis. So for example, if you see this foot, this lesion has a characteristic marking. So you can mark like this. So even the both the legs. So this marks as a rubber slipper. The flip flops will be having a strip over this area. So that rubber when comes in contact with the skin will cause irritation, and it will cause allergic contact dermatitis. So this rubber footwear will contain something called as PPD. It is called as paraphenylene phenylene diamine. Diamine. So this paraphenylene diamine will be there in flip flops. So when the person tries flip flops, then this area will contain will cause an allergic reaction, will cause the dermatitis. So for example, if the women who wears a bindi here now, it will contain a gum on the back side. So bindi will have a gum. The gum will contain something called as PTBP, which is called as para tertiary butyl phenol. So this thing will cause allergy and will cause us bindi dermatitis. It's called as bindi dermatitis. The same way this PTBP can cause bindi leukoderma. The same area will appear white. So for example, if this area will appear comparatively whiter, it's called as bindi leukoderma. And the same thing for this thing, this area will appear whiter than other area. It's called as slipper leukoderma. Then coming to atopic dermatitis. So atopic dermatitis is the chronic lapsing inflammatory condition of the skin. So there will be presence of dry skin, then there will be itching, then there will be history of atopy in the family, or the person himself or herself will have atopy. So atopy, like he might have allergy to something, or he might have bronchial asthma. So for example, in this patient, the flexor compartment is involved. There are three types of atopic dermatitis. So starting from infantile AD, then childhood AD, then adult AD. Infantile AD will involve the face and extensor surfaces. These both will involve flexor surfaces. So as you can see, this involves flexor surfaces like the anterior cubital fossa. Then this will also contain the irritation present along the lips. This is called as headlight sign. Then it will also contain a sign called as Hurtoghi sign, in which the lateral eyebrows will be lost due to repeated rubbing over that area, and there will be constant itching over that area. This is called as white dermatographism. So usually in dermatographism, when that area is stroked with a sharp object, now there will be red color formation. But here you can see there is white dermatographism. This is also seen in atopic dermatitis. Then this is called as Denny Morgan fold. Denny Morgan fold. It is not characteristic to atopic dermatitis, but is seen in when the person repeatedly rubs their eyes. Now there will be extra folds below the eyes. It's called as Denny Morgan fold. Then coming to actually the treatment for atopic dermatitis will be moisturizers for dry area, then antihistamines. If it is severe, now we'll go for steroids. The next coming to seborrheic dermatitis. In seborrheic dermatitis, the most common site will be scalp. We all know it's called as dandruff. So this most common site is scalp. It can be shown. It can be seen behind the ear. It can be seen on the nape of neck. There will be yellow greasy flaking over the seborrheic sites. So it will be causes it is due to hypersensitivity reaction. Hypersensitivity reaction to the body of Malassezia furfur. This Malassezia furfur is a common commensal actually. It's a commensal yeast. It's present in everyone, but when there is hypersensitivity reaction to this Malassezia furfur, there will be seborrheic dermatitis. So if it occurs in infant, it's called as cradle cap. And the treatment will include antifungals, with or without steroids. So then coming to other types of eczema, like these are endogenous eczemas. So this first one will be dyshydrotic eczema. It's also called as pompolix. In this, there will be vesicles all over the palms and soles of the person. It's also called as sago grain appearance. Sago grain is like, for example, it's like a millets. So this will appear like a sago grain thing is called sago grain appearance. And initially for 1 week there will be this kind of eczema. It will be intensely itchy. Then after some days it will dry off and will cause scaling. There will be peeling of entire skin and it will resolve on its own. Then coming to another type of eczema called as nummular eczema. This nummular eczema is also called as discoid eczema because of its shape. It is discoid shape eczema. So you can see it is perfectly like a disc. So it's called a discoid eczema. Then coming to something called as stasis eczema. So stasis eczema is due to venous insufficiency like varicose veins. So venous stasis will be there. So there will be stasis over this area. Then there will be color change over the area and cause eczema. It's called as stasis eczema. Then there is something called as asteatotic eczema. And this one is also called as winter eczema. So it's almost seen in everyone during winter season. It is due to we have always seen that there are some bodies called as Odland bodies in the stratum granulosum, which will produce lipids and protect the skin from water. But this dysfunction will cause something called as asteatic eczema. So usually seen in winter seasons and usually seen in almost every old persons. So in every elderly person this will be seen. So that's all for today. Goodbye.